Hey, Stock Centeno, and I've got the very famous Scott Rosa with me here today. For those of you who don't know Scott, Scott has been really a pioneer in upright MRI, but also in CSF flow MRI. And really, we see year over year CSF flow MRI becoming a bigger deal. And so, Scott's been doing this for a very long time. And also, obviously, has been very involved in seeing craniocervical instability patients, seeing patients with Chiari, diagnosing all sorts of things. And to that, Scott also brings the experience of being a very high level upper cervical chiropractor. So it's an interesting blend of skills that Scott brings to the table. So Scott, let's start with just how did this, and I don't even know the answer to this, how did you go from upper cervical chiropractic into MRI imaging, and how did that happen?
Well, thank you for the opportunity to chat with you tonight and your viewers. As you know, Chris, you and I met many, many years ago. We started out and came in learning about DMX, starting to see about how many people are suffering the ill effects of head and neck trauma. And what happened was, essentially, upper cervical chiropractors, as well as most chiropractors, we've been using X-ray since, I think X-ray was created in 1911 or 12. So that's been our diagnostic entity, X-rays, for the most part. So what happened was that, as you and I probably experienced it as well, I remember after in competing Dr. Croft's course, on brain traumatology,
yeah,
it seemed to be a disconnect. You and I would get patients that would get an MRI that came back saying normal, other than some degenerative changes, but we knew that they were essentially suffering. So I felt that there was some form of a disconnect. And obviously there was. There was, because the state of the art of imaging at that time was really not that keen and sufficient on imaging the structures that you have to help my patients heal up, and the structures that I need to understand to be able to help get those patients' upper cervical area adjusted. So what ended up happening was, it's an interesting story. I was involved in a court case, and I just got my DMX, and we proved the injury, and it was a jury verdict to the patient's benefit. But I'll never forget, when I was being deposed or testifying, the defense attorney said to me, motion X-ray, MRI is the gold standard. And under my breath, I said, you know what? I'm going to try to figure out how to prove this with an MRI. So fast forward, I actually came and hung out with you in Colorado at the International Whiplash Trauma Congress. And while I was there was someone giving out a booklet of information on upright MRI technology. And I don't know how it ended up, but when I came home from court that day, after proving the injury with the DMX, I looked on the top of my toolkit, and there was a booklet on upright MRI technology. And I looked at it and opened it up, and I said, this might be an answer. So I did what I could do at the time. I called up the local upright MRI center, which was in Westchester, New York. And the owner had just opened up, and I said, you might think I'm a nut, but I want to come down and bring patients. And I said, DMX infers bones going beyond their normal boundaries. But I said, it doesn't show the soft tissue. So I said, I'd like to position the patient in the upright MRI and posture them at the angle. I use a goniometer and try to put them exactly where I saw the vertebral segment translate further than it's supposed to, and see if I can see the soft tissue of what it was doing. And Chris, the first case I did, I found a torn PLL. So subsequent to that, I went ahead and one day I started bringing more patients down to this center trying to prove soft tissue injuries. And then the owner said to me, I'd like to introduce you to the inventor of the MRI. I said, well, how do you know him? She said, my father is the VP of sales of Fonar. I said,
that was Damadian, right?
Yes, Dr. Damadian was the inventor of the MRI and the owner of Fonar and the creator of the upright MRI. So subsequently, I was invited down to the Fonar Corporate Center, which is in Long Island, Millville. And I was introduced to Dr. Damadian. I'm in a room with all the board members. And I had a DMX that showed a unilateral posterior arch fracture, but it didn't show up on CT or MR. It only showed up in flexion And on the way back into neutral, the posterior arch popped from its attachment to the lateral mass. You couldn't see it other than with the motion of DMX. So Dr. Damadian, in his infinite wisdom, said, how can I be of help? I said, I'd like to try and hopefully see if you can help me develop methods and means and improve sensitivity and quality of the imaging to be able to see ligaments that oftentimes are very thin and very small that the standard imaging was falling short with. And he said, sure, by all means. So the following week, I brought 3 patients down. It's a true story. And at that point, like maybe yourself, I was used to just sending a patient for an MRI and waiting for a report to come back with the impressions. And long story short, we put the first patient in, and the technician looks at me. He's still there to this day. His name is Rob Veal. He's a great gentleman, great tech. And he said to me, what do you want to image? I said, the alar ligaments. And he said, what are they and where are they?
Yeah, that's probably a common thing even for some radiologists.
And then, of course, Dr. Damadian was not a radiologist. He was an internist. So that's when he went ahead and he was pointing mid-cervical for the alars. And I said at that moment, I'm going to have to build the arc from scratch. So I ended up going and doing dissection for a year and a half, went into Albert Einstein Medical Center, met with the head of the anatomy department. I went with a colleague of mine. We were allowed to go ahead and do dissection with the med students. And the head of the anatomy department, who used to be the president of the Anatomical Society of America, he went ahead and was gracious and said to the med students, he goes, if you want to know about spinal anatomy, he pointed to me and my colleague and said, these are the people you want to talk with. So we did dissection. I looked at where the alars are, transverse, dentate ligaments, and that became the start of the journey, and it just kept going. And I'll be honest with you, probably resonate with you as well when you started, when you were doing pulsed RF. I only started to do the imaging to be able to prove soft tissue injuries. That was my purpose, to help our patients be able to prove their injuries if in fact they sustained one. And then one day I said to myself, we treat patients and they say they feel better. And I said, but maybe I ought to just go ahead and take an image after I do a treatment and see if it makes any changes. And I did that, and we started to see the changes, and then it just went ahead off in so many different directions, including inventing or pioneering the spinal fluid flow studies.
Yeah. So how did that all occur?
Interesting story. So Fonar Corp started to develop a CSF flow software for the Chiari Institute in Long Island for Milrot and Bolognese. This was in 1998, and they didn't take an interest in it. So this is around the time that I had discovered the low-lying cerebellar tonsillar ectopia, where you and I and Michael, Dr. Freeman,
did that paper,
paper of the 1200 cohort. And one night I was scanning a patient up in Latham, where I work out of, and the tonsils were sitting low in a patient, and there was an engineer from Fonar there, who's a great friend of mine. His name is Paul. And I said, man, I wonder what the tonsils are doing to the spinal fluid flow. So Paul went ahead and said, Doc, Fonar started to make a software. It's not completed. He goes, but you ought to call him up and see if you get access to it. Maybe it can help you. So the next day, I did the best thing I could have done. I'm very dear best friends with Dr. Damadian's son, Jevin Damadian. And I called Jevin up. I said, Jevin, I think I might have a use for your CSF flow software. Can you help me out? He said, sure. So the next day, we called the engineer up, the scientist that created it. And Jevin Damadian, Dr. Damadian's son, said to David Shue, who was the engineer at Fonar, that started to build the CSF flow software. So Jevin says, David, Dr. Rosa here. He goes, we think Dr. Rosa thinks he has use for our CSF flow software. He said, can you help us out? And true story, David Shue said, well, I'm busy. I have other projects. It's not completed. And there was a pause in the phone. And then the next thing you hear is David Shue said, am I to assume this is a sentiment of your father? His father was the inventor of the MRI and the owner of the company. And luckily, Jevin Damadian said yes. So the following week, they brought the software up to the center I work up out of Albany. And Chris, it took us a year and a half to perfect it. And while we were perfecting it up in Albany, New York, one of the field service application engineers, who's a dear friend of mine at Fonar, went back to Fonar and said, we don't know what Rose is up to, but what he's doing with that CSF flow, we need to get on board with. And then we just continue to work it. It took years to perfect, but it's just been a blessing. It's been an amazing type of diagnostic entity that really helps us understand flow dynamics, impediments in flow, ill effects to the brain, the vascular system. It's just been amazing.
So yeah, let's talk a little about CSF flow, right? So CSF flow, one of the more fascinating things for a physician is under ultrasound, for example, when we've got the window just right in the upper cervical spine, we can see the dura pulsing, right? It looks like a little heart. It just pulses with cerebrospinal fluid flow. And I think that's something that a lot of people don't understand, is that their tissues in their spinal cord, the nerve roots that come out as you go into the brain, the whole thing is constantly jumping around. And so let's talk a little bit about cerebrospinal fluid flow and what happens if it gets disturbed and what we know at this point. So Scott, what do we know at this point about CSF flow? Because very clear that we know more than we used to, because more and more physicians are using it, more and more centers are offering it, more and more radiologists are getting on board. So what do we know?
Well, first of all, it's multifactorial. There's supposed to be a smooth pattern of ingress and egress of spinal fluid. For the viewers, spinal fluid pumps with every cardiorespiratory cycle. So on systole, when the heart contracts, the lateral ventricles in the brain will contract along with it. And as those lateral ventricles compress or get squeezed, they'll push the spinal fluid through the foramina Monro, third ventricle, and down the fourth ventricle out of the neural foramina into the spinal canal. There's so many pieces to this. Congenitally, some people, there's a morphometric measurement on the angle of the clivus bone and the posterior fossa. If those angles are off in things like platybasia or cranial settling or Chiari, these are things that can actually affect the flow patterns. I have cine flow studies showing the internal skull bone eroding from aberrant spinal fluid flow. I've got flow studies showing the clivus bone being eroded and creating almost like a hook where the spinal fluid came down, hit the hook, and went transversely into the brainstem and created a transverse myelitis. So what we know is that spinal fluid in a healthy human brain and healthy functioning brain is necessary supposed to cleanse the metabolic waste and toxins. Obviously, we know it's supposed to cushion the brain and hold the brain up. But the most important thing was this discovery of the glymphatic system. That's where they put a chemical tracer in the CSF and realized that the CSF is not there just to cushion the brain. It actually is there to remove the metabolic waste and toxins. So when we talk about the upper craniocervical junction, to the work that you do and we do structurally, it's called a choke point, or can be called a choke point for craniospinal hydrodynamics. So when C01 and 1 and 2, there are 3 rings. If there's any malalignment within those structures, they can create what we call a choke point for craniospinal hydrodynamics. That can be multifactorial as well, because it doesn't only give the opportunity to affect the spinal fluid flow, but when C1 rotates, as you know, you've done amazing podcasts, as it rotates, the transverse process of C1, we oftentimes see a lot of these mechanical compressed jugular veins. Mm-hmm. Not just the jugular vein compression, it's of interest. Sometimes it's a problem, sometimes it has no issue whatsoever. But that jugular vein is encased in the carotid space, or the carotid sheath, and within that is the jugular vein, the carotid artery, and cranial nerve 9, 10, 11, and 12, which is why when I send all these patients to you that I'm referring for your work, I'm doing it because the joint laxity is literally somehow affecting that carotid space, and I believe it's affecting cranial nerve 9 is the glossopharyngeal nerve, cranial nerve 10 is the vagus nerve. The neurological, neurovascular, neurobiomechanical, and craniospinal hydrodynamic implications become vast. So back to the CSF. So if it's impeded, it will start to back up. And as it backs up, it'll start to create or increase the intracranial pressure. Intracranial pressure rising can start to squeeze the brain. As the brain gets squeezed, it can get stiffened. It's called compliance. And as it gets stiffer, it becomes more difficult for the exchange of nutrients in and metabolic waste removal. So we've got the plumbing, which is the arterial blood in for nutrients to the brain. You've got the CSF as a manner of creating an opportunity to remove metabolic waste and toxins. When those toxins are basically eliminated, they're brought to the top of the brain, to the arachnoid villi or arachnoid granulations, which filter out metabolic waste and toxin from spinal fluid. Then it gets deposited in the superior sagittal sinus to be drained out through the jugular system. And if there's impediments in CSF flow and there's compression or ill outflow of the venous system, I use the analogy that instead of the brain sitting in an environment of Miracle-Gro, trying to stay healthy or trying to heal when there's concussion or MTBIs or TBIs, it's actually sitting in an inflammatory environment because it cannot get rid of those metabolic wastes and toxins efficiently. And it's interesting, Chris, if you've been following, I know you do as much as I do, I think they're saying by 2030, there's going to be, I think, a 40 or 50% increase in Alzheimer's and dementia. Yeah. I am telling you, it's my hypothesis, but I do not believe that that is genetic. I believe that we're in a world where trauma is more robust. You and I know, what was it in 84? The papers that Croft taught us was that there was a 268 increase in percent of neck injuries when they enacted rigid bumpers and seat backs. So we're just doing more trauma these days. So then you deal with that. And then, of course, when the cerebellar tonsils settle in to the foramen magnum, whether it be from a Chiari malformation, whether it be an ectopia due to intracranial pressure, or the misalignment, the atlas misalignment, there are denticulate ligaments that anchor the cord in the brainstem in the middle of the neural canal. And the dentate ligaments are angled caudally towards the ground. And I confirmed this with the president of the Anatomical Society of America back when we were doing our paper. I said, my hypothesis is that when the craniocervical junction malaligns, it creates a caudal or downward pulling tension on the brainstem and the cranial elements. And then I said, and I believe that because when we do the pre and post imaging studies with CSF, we oftentimes see the cranial element of the tonsils will migrate up enough to improve the flow. And if the flow improves, more often than not, the patient reports feeling better. So the anatomist said to me, unless someone can come up with another explanation, he said it was the most logical.
Yeah, so that's an interesting concept. So just to review that for everyone watching. So when there's a misalignment in the upper cervical spine, as you know, craniocervical instability then starts to play in here. We can see those dentate ligaments get or sort of pull down the brain, causing more of a stopper effect with those cerebellar tonsils. When you can realign that and have it stay in place, you would get more flow in there because the cerebellar tonsils go up. And we've just talked about this dual concept of the stopper from the cerebellar tonsils with, let's say, a Chiari 0 or a Chiari 1, and then the instability bringing that transverse process around of C1, putting pressure on the IJVs. That may be intermittent compression, right? So that compression in certain positions may be much more for that patient. And then you've got all of that interfacing with concussion, where the brain is trying to heal, but it's sitting in its own garbage, if you will, not able to get rid of the garbage or the toxic waste products of the brain, because all of those exit points are either getting intermittently blocked or statically blocked. So from a treatment standpoint of trying to get everything realigned, when you can get things realigned, what do you see with your CSF flow patterns? Because, again, for everyone just joining us, cerebrospinal fluid flow analysis is what Scott has really developed. And he has combined that with upper cervical chiropractic. And then tried to look at before and after. So what happens when things go back into alignment?
So great point. First of all, some good news from a data collection standpoint. Dr. Damadian sadly passed away a couple of years ago, but spent many years going ahead and creating an understanding of what normal flow, volume, and velocity is in contrast to abnormal. So we do have a reference of what normal flow, velocity, and volume is. So we have a reference point. And so what we see is that when the atlas misaligns, when you get that misalignment, the atlas, when it malaligns, will go up and around the occipital condyle. And as it does so, it's creating this downward pulling. So when we realign the atlas, what we will see, and so far, we have not seen where the proper alignment had not allowed the cerebellar tonsils to migrate up enough to make more room for the spinal fluid to flow. And I want to add into this in your venue. When you've got a retroflex dens and you've got tectoral membrane, alar, transverse ligament insufficiency, when you get the retroflex dens, not only can there be suspicion of ventral brainstem compression, but if you got blockage in the front, and that retroflex dens will block CSF. And then you got the tonsils in the back, this is where you get this enormous cork stopper model. So what we see is that when the alignment is good, the downward tension releases, and then the cranial elements will usually rise up enough to allow more room for the spinal fluid to flow. It's interesting, Dr. Bolognese did a paper where he said that, and I have seen this experience myself. I've had patients with 18 millimeter Chiari 1 tonsillar distension that after alignment only went up to 16 millimeters. But the 2 millimeter rise created enough room around the foramen magnum to allow normal flow. I can't tell you how many patients we had that were scheduled for decompression, Chiari decompression, that never needed it. To be honest with you, Bolognese wrote a paper. I'll share it with you in the next few days. He wrote that sometimes the cerebellar tonsils will come down. They won't meet that 5 millimeter threshold that traditional radiologists are using. And I think it's a bad number, because Bolognese says it doesn't matter how low they are in this paper that he wrote. He said it matters, are they impeding the flow of spinal fluid? And he stated, and I see this often, where the tonsils will come down just at the opening in the foramen magnum, kind of similar to the Chiari 0 model that we know. But they'll come down, they'll wrap around the brainstem like snails, and they have just as much of an impediment of flow, but actually have more influence on the brainstem because of the way that they're wrapping around, not being thin and long as a Chiari malformation normally presents, but actually the tonsillar distension due to trauma. And that's what our paper with you and me and Dr. Freeman showed. There was not one real Chiari patient in that paper. Those are all trauma-induced tonsillar ectopias. So that's what we see. Alignment will help migrate to the greatest degree that it can the pulling up of the cranial elements in the tonsils to make sufficient room, more often than not, to allow the spinal fluid to start to flow in a normal pattern. And I will say, with patients that usually have that brain fog, along with what we know brain fog can be due to CCI and various other things, but the brain fog is something that we do note when that spinal fluid does start to flow better. We oftentimes, on average, usually about 3 months, 3.5 months, we usually start to see that cognition start to improve. Some start earlier, some go later. Jim McMahon, the quarterback we treated, he took 13 months to get his cognition back, but we used to have to send a car service to get him to come up when he would come up to get treated because he couldn't remember how to get home. Now he can rent a car, drive up, get treated, and go back and fly back to Arizona.
So, so for everyone watching, a couple things. We're going to get to questions here for Dr. Rosa and or myself in just a few minutes. In addition to that, I want you to like this video, because that's how other patients can find it. Because we have patients that join us live, but we have many more patients that watch this after. So please like this, because Scott's given up his time here, and I know his time is very valuable. And we want other patients like you to be able to find this. And so, Scott, let's talk about one last topic before we go to questions. And that is this more recent research that shows that there actually seems to be a mechanism that we've known about for a while, that rectus capitis posterior minor through the myodural bridge opens the back door, if you will, for CSF flow in those Chiari patients, and that the suboccipital nerve is involved there, causing denervation of that muscle. Right. So basically, taking away the automatic door opener. So what are your thoughts on that new research? And I'm sure it's stuff you've contemplated before the research came out, but what are your thoughts on it?
You and I have been observing this for a while. When I send you our imaging studies on the patients we refer to you, we do that RPM, that CINI study. RPM stands for rapid pulse modulation. That's
Okay.
where we put the patient in flexion. And then I personally go in the room and move them. I move them in small increments, and every 11 seconds we shoot an MR picture, shoot an MR picture, shoot an MR
Oh
picture.
yeah, that's the moving one.
The RPM, yes, sir.
Yeah.
So we see it so often, and I always tell the patient when I see that, I say,
Buckling.
yeah, I call it a blowout, literally, because the job of the myodural bridge is to prevent the infolding when we look up into extension. And of course, I always say you got to go to Dr. Centeno. He can inject that area and get that area to tighten up. But it is, first of all, as you know, Dr. Hack, the dentist, was the one that discovered the myodural bridge. He was also the one in his paper that said that could be at the root of headaches, because the myodural bridge, the dura is pain sensitive. And where that myo means muscle, dural is dural. So where the myodural bridge inserts into the dura, it's supposed to prevent the infolding of the dura when we go into extension. So when we see that enfolding on that sinew loop, you can see it on static images sometimes. We've been taught that. We saw that in Cocaigne's work and so forth. But when we see the movie and they go up and that thing moves in and out and in and out, it's not only the fact that it can impede the fluid flow. It's not only the fact that it can go ahead and put compression near the cerebellar tonsils. It's also the fact that that movement up and down is pulling back and forth on the dura, and that can manifest in suboccipital headaches or pain. It can come around the head. It can go up and over the head. It can go down the neck, which makes it confounding for us because there's so many things that can also have those types of symptoms. But my feeling is it's about time that they went ahead and realized that that is a very important piece of the puzzle for both you and I, for me for diagnosis and treatment, and for you, for us to send them to you to inject those structures, the greater occipital branches, as well as that whole occipital ridge, to try to get that tissue to tighten up. Because as long as that tissue keeps moving in and out and in and out, depending on the patient's work, if they're postured down all day long, if they're painting ceilings, if they're looking up and down, this becomes a catalyst for them to start having pain and dysfunction. And of course, when they go for the standard MRI, they say there's nothing in there, it's normal and so forth. So I think that paper was a fabulous paper in its description. I think they're commenting about what it does when it's visualized, but they're not talking about the genesis, meaning we're the genesis. The trauma creates the hyperflexion and hyperextension injury, overstretching the myodural bridge. And once it's overstretched, that's when that mechanism starts to pull on a tissue, on a structure that ended up doing more than just creating suboccipital manifestation of pain and dysfunction, but it also was found to obstruct the flow of spinal fluid.
And just so that you know, we have started to treat that suboccipital nerve runs in the same plane, just posterior to the rectus capitis posterior major there, as the greater occipital nerve. So we have started to treat and hydrodissect that plane to try to treat it. So let's take some questions here. So we have AT, Dr. Rosa, thanks for your time. Is the main mechanism of how AO helps CCI in that it reduces rotational forces on the CCJ ligaments, especially alar, better allowing the area to heal? So what are your thoughts there?
Yeah, great question. So when an atlas misaligns, it misaligns in a three-dimensional plane. And don't want to get into too much into biomechanics here, but it's a coupled motion. As the atlas misaligns, it goes up the occipital condyle, and as it does so, it's going to exert strain on the craniocervical ligaments. That's going to include the alar ligaments, the accessory. It's going to include the capsules. It's going to include the suboccipital muscles. So the whole purpose of the AO correction, or the atlas realignment, is to restore the atlas into its normal position. Because as we all know, ligaments' job, other than the ligamentum flavum, all ligaments' purpose is to hold bones tightly together. And if this hand represents a vertebra and this hand represents a vertebra, if you have a malrotation between these vertebral segments, there is likely to be a load on those ligaments. And that is not helping those ligaments heal, which is why we refer so many patients to you, Chris, because we usually get the patients, we're a last resort. And by the time they've gotten us, and you've spoken about it, Some of them have had therapies. They all have therapies with good intention. But as an example, I am not a fan of traction. When you've got a craniocervical junction that is somewhat laxed and those joints are loose, the last thing I want to do to a ligament that's job is to hold the bones tight to reduce dysfunction and movement is to stretch them. That's another thing I don't particularly appreciate or resonate with Dr. Bolognese. When he wants to know if you need a fusion, he's going to put you in this hard collar traction. And I've had patients come to me after that. It's a problem. So to answer the question, AT, and thank you for the question, the whole idea is restoration of alignment between C01 and 1 and 2. I mean, obviously, when we adjust the atlas, it's correcting the spine down to the tailbone. I treat many low back patients with the atlas correction. So the goal is to restore it. And when it does come out, it will go either right or left, and it will rotate either forward or backwards. And the job of me and other atlas doctors is to find those misalignments, measure them, and be able to understand how to exquisitely, safely, and carefully restore that malalignment back to normal position.
Gotcha. Rishi, Dr. Rosa, how do you know if it's possible, or I guess, do you know if it's possible to reverse upper cervical muscle atrophy once fatty infiltration has set in? Rishi, there is a study, a pilot study by Jim Elliott, who many years ago used to be our physical therapist. Now he actually is a professor down in Australia, where he showed that it was possible to reverse it. Scott, what are your thoughts there?
James Elliott presented with us, I believe, when we were in Sweden, Chris. If you
Yeah.
He was the one. Yeah, he was the one that did the research and found that the fatty infiltration of the rectus capitis and the multifidus muscles was due to like a whiplash type event. My answer is that I always tell patients alignment will obviously help, but I always tell them that you have to go to Dr. Centeno, because if you can't get those greater occipital nerves to start activating and refiring, I don't know that those muscles are going to go ahead and restore if they don't have activation from a nerve to create them to do so. Does that make sense to you, Chris?
Yeah, that's one of the reasons why we've started more aggressively hydrodissecting around that suboccipital nerve that innervates most of them, because that rectus capitis posterior minor paper with Chiari was super fascinating because it seemed to show denervation, and so they went back and said there's something going on with this nerve. So that's why we've added that. Let's see. AT, Dr. Rosa, AO docs say if C1 holds, the neck curve will correct itself. CBP docs roll their eyes at this and say there is no research to validate these claims. Ever consider doing a study to prove this? So what are your thoughts on that the curve will correct itself if we get things properly aligned up there?
Having a curve in the neck is unique to every single patient. Some patients can have a curve back, some patients can't. Sometimes they can't have a curve back because part of having a curve has to do with many factors. If you look at a cervical curve on a healthy human spine, the anterior disc is usually going to be higher in front than in back. If you get a patient that has mid-cervical severe degeneration and buckling and spurring, you can try to force that curve back as much as you would like. I am sorry, I have not seen those types of environments be able to restore a curve. I would agree. I can show 100 or more, probably more than that. I can show you curve restorations. In fact, I'm going to send you a PowerPoint. We're getting ready to publish a case on 3 MS cases where there was lesions, and then after alignment, not only did the lesions go, but the curve is restored. So I do see curves restore when the atlas is correctly aligned, because posture is controlled basically via many neurological systems. The reticular formation is part of this. And neurologically, the job of the atlas is to keep the head in a vertical posture. And if the atlas misaligns, it's going to tilt the head off vertical. And when it does so, the eyes have to be level with the horizon. So when you do that, the head will come back vertical, but it'll cause a distortion in the spine as an adaptive model. So curves, as I say, some people can have a curve, some people can't. My mentor, Dr. Sweat, showed us that some people can generally, their foramen magnum is a little bit further back in the base of the skull. And therefore, in order to have the head hold up, their spines have to be straighter. There are studies that my mentors showed us where, depending on the angle of the facets, if the facets are too flat or too angled, that can affect the curve. So I respectfully am not of the opinion that only, and I love where the best of friends, Dr. Katz, I know Dr. Katz has a great curve restoration program,
Mhm.
but I can show you hundreds of cases where we only adjusted the atlas and the curve was restored. And the difference that we find is that when the atlas is correct, it will do its best to restore the posture as vertical and try to improve the curves as much as possible. And when we do that, we oftentimes see longevity in the curve holding. So that's been my observation and my experience. So I do believe that, do I have time to do that type of study? Maybe in the future I will. A couple of my colleagues are talking about it, but I absolutely can show before and after imaging where the curve did restore by merely doing the atlas correction.
Gotcha. Guys, if you're just joining us, hit that like button because that's how other patients find this content. Raj, hi doctor. I find it hard for a chiropractor to move a bone in the neck with their hands or a device, as bones are rigid and are stabilized by ligaments and muscles, ? So I think Raj is struggling with the idea that these bones can get out of place and you can move them back in place with relatively small forces in a very specific direction.
Yeah.
So tell us about, Scott, what your thoughts are there.
Yeah, thank you. It's a great question. Well, first of all, they've been adjusting the atlas in my profession since 1930. And I've been doing this it'll be 38 years in October. And I'm here to say that after 38 years, if I wasn't able to move the bone in place, I don't think I'd still be here for 38 years doing what I do. There's a mechanism of how we move the bones. The procedure that I use, we have to put the patient in a very specific posture and position. The patient lays on their side in a fetal position. We have a headpiece that's designed with very firm foam. It acts as an anchor to prevent the head from toggling or moving. We induce a force. Now remember, when the atlas bone misaligns, it's not misaligned in an inch. It's misalignment within millimeters. So it doesn't need a sledgehammer to move it. But what we do is we position the patient in what we call a pre-stress posture, where we're raising their head a little bit above level on their side, which is with tension and physics, it's creating a mechanical stress wanting to move the bone back towards the midline, towards the position it's supposed to go into. And then the imaging, we take measurements on the vector, the angle at which we use the instrument to gently tap the bone back in place. So we're moving it the thickness of a bunch of hairs. So the answer is we've been doing it since the 1930s. It doesn't take a lot of force to do it the way that we apply it. And of course, to Raj's point, there's two ways to move the atlas, or more than two ways. If you do manually, and I'm not against those that do it manually, when you do it manually, you have to overcome muscle tension and muscle reaction. When we lay the patient down on their side, ask any of our patients, you do not feel any pressure. You don't feel any muscle tension or stress. You hear a little click, and when we do a pre and post image, and it does show the bone restored. And that's the other thing, to Raj's point, I'll be happy to share with you or him. I've got thousands and thousands of pre and post imaging studies showing the bone malposition and then showing it back in place. So we are able to move it gently and safely. And if Raj wants to have more questions, I'll be happy to discuss it with him.
Great. Diana, asking about, do we assess for vertical cranial settling when we look at patients? Now, we do look at BDI, Bayesian-Dens interval there, and certainly see some patients that have a very low BDI. Realize the concept of cranial settling is a little bit more than what we generally see, right? The concept initially was there is a patient population where the dens actually goes into the foramen magnum and starts putting pressure on the medulla. Then as we go into our patient populations, we generally don't see that. So Scott, what are your thoughts on cranial settling? I know there's, Dr. Bolognese heads down that pathway. some of the other neurosurgeons head down that pathway. What are your thoughts there?
I have scanned quite a few patients that we found that were having a constellation of complex symptoms that did have cranial settling. It's pretty easy to see. It's not only the BDI. If you look at an MR, a sagittal view, and the dens is above the hard palate, there are other lines of mensuration that one can use. And to your point, when a patient has that, and posturally, if they go into flexion, that's when you can start to get near this ventral brainstem model. And ventral brainstem compression has a laundry list of symptoms that can come about from it, some local to the area and some distant. So the question is, do I see it? Do I look for it? Absolutely. Have I treated patients with it? Yes, I have. But those are anomalies. Those are congenital, and they do have to be treated very carefully. And even from an atlas perspective, a treating chiropractor, you can't do manipulation on those patients, in my opinion, and you can't do traction on them unless you're Dr. Bolognese trying to assess if he thinks they're a surgical candidate. But they're out there. We see them. They got to be handled very carefully. You have to explain to them what you see, and then you have to correlate it with their symptoms. And I'll be honest with you, I believe I've sent several patients that have had cranial settling to you, Chris. And between alignment and your work, they're doing well. They're doing well.
Yeah, and so it's one of the reasons why it's less concerning for me unless I see obviously quite a bit of compression. Rishi, what are your thoughts on occipital nerve decompression surgery? There's lots of these patients that have chronic occipital neuralgia. Most of them get this before they see me, probably some before they see you. What are your thoughts on it?
So that's a great question, and I have a lot of experience in that. I was actually honored. 2015, I was invited up to a very prestigious Chiari conference up in Buffalo, New York. I was asked to present on my work, and one of the things I discussed was not only alignment in the work that you're doing, but I discussed this 5 millimeter threshold. I just said, you need to throw it out. It's not good enough. You have to go ahead and gauge it by the clinical presentation. So the problem with the occipital nerve decompression surgery is that oftentimes in their attempt to make more space, they're going to go ahead and destabilize the area because they got to cut through muscles. Mm-hmm. Sometimes they cut off the posterior arch, and that posterior arch is part of what you and I need for some sense of stability in the craniocervical junction. So decompression surgeries are sometimes needed in extreme circumstances. But again, I'd have to say, in my years of experience, I think I've only had one patient out of all the Chiari patients I treated, and I treat a lot of them. I've only seen one patient actually go for the decompression, and sadly, they were unhappy that they did. So if you're getting neurological deterioration because there's brainstem compression and you're starting to lose, problems with breathing and heart function and so forth, that's a different story. That's kind of a rescue. There's no other choice. But I would always tell a patient that has a Chiari, I would say if it were me, I would try the non-invasive, i.e. alignment, and see what we can do as a team to try to help that area stabilize. As you know, Chris, people that have Chiari do not know they have it until an inciting event like a trauma brings about the symptoms. Mm-hmm. So they live a life of fairly reasonable function until something ticks it off and then turns it into a symptomatic nightmare. So our goal is, well, if you existed with it before, what has changed in that model? And usually the trauma, like a whiplash injury or a sports-related injury, can take that area, destabilize it, and then the destabilization is more of the impetus of the problems with symptoms than the actual Chiari might be, in my opinion.
Yeah, I agree. I tell the same thing to patients. Listen, you had this Chiari before, you were living a normal life, and then something happened. So we got to trace back to what happened and try to fix that. And then when it comes to greater or lesser occipital nerve decompression, Rishi, as you know, my thoughts on that, as Scott was bringing up, they have to get to the spot, and getting to the spot that they're decompressing obviously does some damage. Having said that, there are probably some patients out there where there's nothing else you can do. Let's see.
Chris, one last thought, Chris, on that one before I leave. If you remember back in the day, they were doing those rhizotomies. Remember those?
Yeah.
And so I think to the occipital nerve decompression, when you start cutting nerves, nerves have a function. And if you cut that nerve, whatever that nerve is going to will not have that robust function. So it's not just from the structural perspective of what can happen when they do these decompressions, but it's also the neurological sequela that can come from that.
Yeah.
In my opinion.
Joanne, how after a PICL, an average patient notice improvements in ligament tightening? Joanne, that's 3 to 4 months. Some patients longer than that. Most patients are in that time frame. This is a shout out from Amelia, who is basically saying what I have witnessed many times, Scott, and that is that, as you know, upper cervical chiropractic is only as good as the vectors. And sometimes, you and I have both experienced this, a patient will see an upper cervical chiropractor and the vectors are wrong or inaccurate. So talk a little bit about that. Why is that? What happens? I know that you've been able to transmit your vectors to countless upper cervical chiropractors I work with, and all of a sudden things start working. So how do they get the vectors wrong? What happens there?
So thank you. It's multifactorial. So we've been using X-rays to measure misalignments to create the vector to make the adjustments. And I often talk about this because I teach this in a 3-year program to Atlas doctors. It's a diplomate program. And our forefathers, when they created these models of misalignment measurements, vectors, and correction, they were not at a time where CCI was at the level that we have it now, right? So what I've learned is that the model of, in fact, I just taught this last October, the model of misalignment corrections have to be, in my opinion, have to be modified when it comes to CCI or suspicion of CCI patients or people with craniocervical syndrome. So I've had to learn that literally, and I had to learn it the hard way because we get so many of these types of cases. The traditional model of headpiece height, headpiece angle, positioning, that is a piece of this equation. I teach if the doctor raises a headpiece that the patient lays on, one click too high or low, that can absolutely not allow the correction to go as smoothly and optimally as you would like. It's no different with your work, Chris. If people are attempting to go in there and inject and they're not using what you're using to get near C01 or get to the alars or anything like that, the capsules, if they don't have dye in there to know where the vertebral artery is, you're going to miss it and it could be catastrophic. So one of the components is patient positioning and setup is key with a CCI case, and I mean that extensively. Number one. Number two, my profession, again, has been using X-ray. Now, a lot of the profession is adopting cone beam CT, and cone beam CT is better or can show more than X-ray. And X-ray is a 2-dimensional shadow. Cone beam is 3-dimensional. But with me, I use the MRI. And the MRI is 3-dimensional, thin slicing through C0112. I can see anomalies on the MRI that you just will not find on an X-ray. You just can't see them. So the fact that I have a roadmap that is a bit more 3-dimensional, I'm able to look at the joint dysfunction and misalignment, the design of the joint. I can't tell you how many lateral masses and condyles are asymmetrical. And those asymmetries play into how I have to make the vector. So the answer to the question is the reason my vectors, I believe, have been helpful is because I use a roadmap, i.e. the MRI, and I thin slice through the C0112 joint, and I'm able to understand the biomechanics of how the bone misaligns, and I've actually created a protocol to adapt to those anomalies and create vectors that can help, in many cases, obviously, try to make a great vector. And if the doctor that we give, in fact, what I do is when I create the vector off of these exquisite images, and then I send the vector to another Atlas doc, I also send them a picture of the setup. And I tell them, just set it up and do it the way I do it, and you'll get the same outcome. And that's what we've been seeing, thankfully, in some cases. Back to the original point, all Atlas doctors do great work. And there are many different programs out there, and I respect them all. Many of them are my friends. And always remember this. This is something I do have a problem with my profession. The idea of, who's better? There is no better. A Atlas correction is only as good as the hands that are applying it. And that goes for you in the work that you do.
Mm-hmm.
So that's part of the process as well. It's how well and how masterful the doctor is, whatever Atlas procedure they're using, in applying the correction and having the right vector or line of correction. And that's what yields really nice outcomes, in my experience.
Gotcha. Yeah, I would agree. I mean, it's obviously the same thing for injections. Edward, how often do you recommend surgical intervention? This is for you, Scott, to your patients. How do you come to that determination, and generally for which subconditions?
So I've been very lucky. I don't get 100% success. No one does. But we've had this conversation, Chris, had quite a bit. Ed, what I would say is I will exhaust everything I can structurally, and then co-managing my cases, my patients with Dr. Centeno, to try to bring about the best outcome possible. Because you have to remember, surgical fusion of the craniocervical junction, Chris, you and I had that issue years ago when one of the surgeons went ahead and put the screw through the lateral mass into the occipital condyle.
Yeah, through the 0-1 joint.
And then you and I and Dr. Harshfield were the ones that said, has anyone ever done a study long-term on how long those fusions last? And there was a study done. And I think they said at the end of 5 years, there was over a 40% failure rate. So I will exhaust everything I can from a non-surgical perspective. So when you ask how many or do I come across, it's very rare. And if I had to have someone have that type of surgery, the top of my list is going to be a Dr. Henderson. I know his work. I know him very well. I think
he's gonna be doing this next week.
Yeah, excellent. Oh man, he's amazing. He's amazing. And he was great friends with Dr. Damadian. And
okay.
Oh, in fact, I'll send you. There was a wonderful YouTube video that he did. He invited Dr. Damadian down years ago, and Dr. Damadian, all he was talking about, 2/3 was about MRI and stuff, but the last third is all about CSF and about the work that we're doing. So Henderson would be amazing. So Henderson would be at the top of my list if I was going to need to refer a patient for a surgical intervention. Not being disrespectful to the other surgeons that we know, but I also am not a fan of doing C1 and 2 without doing C01. C01 is just a significant joint that can have adjacent segment disease as any other joint. And as I know, and I've seen, and probably you as well, C0 is what sits on top of the atlas. Atlas weighs 2 ounces. The human head's about 14 pounds on average. What's holding it on to the atlas? Capsular ligaments, tectorial membrane. We got a lot of little thin structures. We got a lot of small, very minute suboccipital muscles trying to hold your head on top of the atlas. You and I have discussed this. C01 is creating more problems than we've imagined. The beauty is the DMX is showing it to us now. And I've had cases with you that I sent you and said that C01 is not right. Can you do something? And you did, and those cases came out wonderful.
Well, thank you. It's an interesting one here from Pia. Can you talk about the upper cervical position in relation to jaw position? I used to push my atlas back, and it gave me more room for my jaw. Yeah.
So there's a very strong interplay. There are what we call orthogonal dentists out there. The interplay is it's a 3-pivot system. The C1, C2 joint, dens, atlas around the dens, and the 2 TMJ joints. And I have a colleague, Dr. Vita, who does orthogonal dentistry. And he will not do any sort of dental reconstruction or occlusal changes or orthotics unless the atlas is perfectly in alignment. Because if the atlas is malaligned, that 3-pivot system will go into an imbalanced state, as well as the neurological component. The muscles of mastication, 75% are fed from the craniocervical junction. So if there's craniocervical dysfunction, you and I see it often. It's not unusual. People are going to have TMJ and occlusal problems, airway problems, breathing problems. It's very common. So there is an interplay between the TMJs and the atlas misalignment. And I would say if you want to have your jaw looked into further, obviously a dental specialist, a TMJ doc is good. But I would also say get the atlas or the craniocervical junction checked.
Let's see here. It's an interesting one. After your AO treatment, is PICL always needed, or is it possible to utilize posterior PRP?
Mhm.
So Penny, that all depends on the type of craniocervical instability you have. So Scott, what before we got involved, you were probably working with some patients that were getting more just traditional posterior prolotherapy. What was your sense of that? So that probably gets to more of the heart of this question.
So, as I've always said, these are multifactorial components involved. What led me to understanding where posterior neck wouldn't be sufficient enough, if you recall in the beginning, we've been working together since you started this, and I'm blessed to have you as a colleague able to help so many of my patients. But, you would start with the posterior neck first.
Mm-hmm.
You would wait several months and see how much can improve. And if there was some improvement but not sufficient enough, then you would consider going in for the PICL. Now that we have imaging at such a high understanding, DMX, upright MRI, now that we can see these components, what will happen is that, if I have a patient that has a DMX and they're showing multi-levels of intersegmental instability, I believe a posterior neck will be advantageous. We'll send them to you for that. But as soon as we look at that DMX, we did that paper, Dr. Katz and I, where we found that, and Dr. Freeman, of course, we found that up to about 3 millimeters is suspicious for CCI. And I use that term clearly with my patients when they come to me. Before I decide to send them to you, I say, at the moment, it's suspicious. How do we know it goes from suspicion to confirmation? One thing is that if it goes 3 millimeters and more, that was a threshold that we found was pretty strongly confirmatory for a CCI. Mm-hmm. The other thing would be is that if the posterior neck helped the patient, but there's certain residual symptoms. Now, we know those symptoms very clearly. When there is CCI is not going to affect your arm and hand. That's going to be more mid-cervical. But when you're talking about nausea, dizziness, brain fog, headaches, craniocervical in nature, that's where I'm going to probably want to go and point towards the PICL, along with our imaging, MR, Dr. Katz, or my DMXs. The imaging becomes the roadmap in my experience. And if the imaging demonstrates to me that they're meeting a threshold, that's when I'll ask you to please go ahead and consider not only posterior neck, but also to consider doing a PICL. One other caveat I have found in my experience, and this might be yours as well, if you do the PICL and that mid-lower cervical area is still a little bit laxed, I find that they don't hold as well, which is why when they come back a second time, I'll respectfully request that you consider doing a posterior neck, because if you don't have that mid-lower cervical neck to hold the atlas and the head up, then it does put a mechanical strain on the craniocervical junction.
Yeah.
Sure.
Yeah. Ben was talking about, is it possible to have craniocervical instability with just a low clavoaxial angle? And sounds here like he's asking if changes in shape of the curve can affect the CXA. So what are your thoughts on that?
So correction of a misalignment at the craniocervical junction can absolutely change a CXA. I have hundreds of images with DINs that are retroflexed, and after the alignment, when I do the post-MR, they'll either come up vertical or they'll move away to create more space to move the DINs away from the brainstem and allow more space for the spinal fluid to move. So certainly alignment and improvement of the curve can help that. And remember, you and I have had this discussion, I believe. Measurements are there, and measurements give us some ideas about things, but they're not the holy grail, because clinical symptoms still have to come into play. My first mentor taught me the only constant in human health is a variable. Everybody's different. And what CXA might be causing severe pain on one person, as you know, might be asymptomatic on another. So that's why you do the great evaluations and you do your exams, and I do the same. And then we come up with a working understanding. What I've always tried to do, and I know you do as well, when a patient comes in and says it hurts here, it hurts here, it hurts here, it hurts here, I try to use the imaging to see if I can see a nexus or an association to the areas where they're complaining. And more often than not, maybe not 100%, but more often than not, we usually are pretty successful or accurate in finding those associations. And again, it's usually leading to some degree of instability that, co-managed with your procedures really makes a difference.
And this is a good one to end for today on. Robert, I worry about that there aren't any successors to both of your legacies. I don't know many pioneering this much as both as you're doing. Robert, I know Scott teaches, so he'll probably talk about that. We've got other docs in our clinic that I've been training in PICL, so that's going to continue. We're also going to pick select clinics around the country. We're working with a Florida clinic right now to try to get them up to snuff over the next year. And Scott, I know you teach extensively through your organization, so you probably already have successors out there from that standpoint. But how about on the imaging standpoint? At some point you're going to retire, and what's going to happen there?
Okay. Rob is a great guy. He has been really he's a pioneer in helping so many people that are on the various Facebook pages that are struggling. And he, of course, has had his struggles as well. Mm-hmm. So I teach a 3-year, 300-hour diplomate program for the International Chiropractic Association. That's I teach the imaging portion, and I teach risk management. I teach trauma, whiplash and such. So that's all different types of Atlas doctors. It's NUCA, and it's Blair, and it's AO, it's orthospinology, and so forth. In terms of the work that I do in Atlas Orthogonal, at this point, respectfully, we have a lot of great docs out there. And there are about a handful that I have worked with that have shown a level of mastering skill that I'm confident when my time comes, there'll be people after me to go ahead and carry it on, as I know that you have to do the same thing. So I'm working on it. It's not easy. My first mentor taught me that 10% of the people doing what they do are superstars. 80% might not know the difference, and the last 10% shouldn't be attempting it. So we really need that top 10%. You can talk about a pianist, an athlete. They're just people that just have that drive to want to become masterful at what they do. And we try to find those folks, and we try to work with them, and they are the future, certainly for the work that I'm doing. In terms of the imaging, yes, I have a few docs that I've been training, and we'll continue that on. We'll make sure that that stays.
Well, great.
Thank you, Rob. Thank you, Rob. I appreciate Rob quite a bit. He's a gentleman.
Yeah. So guys, I want to thank Scott for being here because we're hitting the hour mark. And I know he's got a busy schedule, so it was great that he decided to do this. He was on once before, so there's another video you can look up that Scott and I talked about lots of different things. Give us a like on the way out because that helps other people find this. It helps the algorithm get CCI patients connected with this, Chiari patients connected with this, patients interested in CSF flow. And Scott, thank you so much for being here tonight. And we will make sure we have you on again here at some point in the future because it's always interesting when Scott Rosa comes on. And again, these are such timely things. Realize that Scott did this work with the originator, if you will, of the MRI, the inventor of the MRI, Dr. Damadian, took a rough piece of software that they didn't really understand what they were going to do with, and then turned it into what we now know as the CSF flow study. And that CSF flow study is now being used by lots of people, not only clinically, but in research to start looking at how important this cerebrospinal fluid flow is in overall health. So thank you, Scott, for doing all that. And thank you for helping the patients I see. And thank you for your support of our practice through the years.
And thank you, Chris. And thank you for the people that logged on. And again, I speak your name daily. And we started back a long time ago with observations and thoughts and ideas about what do we do with these patients. I often tell the story about when you were doing a post-RF, it would help pain, but it didn't address the instability. And I always thank and bless you that you took upon somehow figuring out how to stop and how to improve that joint laxity. And as you know, I refer hundreds. And
thank you.
Thank you. I always tell patients that the two best therapies that I know of that exist today in a safe, gentle, and really efficacious way is structural alignment and then subsequent follow-up with your interventions. I will leave you with this. I have had patients, I know you see this all the time, and maybe you don't get the accolades for it, but I can't tell you how many patients we have that were disabled, couldn't work, that between our work and your work have been able to return to work, return to activity, live a functional life, and there's nothing better than helping the sick and suffering. So, Chris, thank you for all the work you do.
Well, thank you. Thank you as well, Scott. Guys, thanks so much for joining us, and have a great week to everybody.
Okay. Thank you.